Good afternoon. Welcome to all. So we are at the fag end of the session of the BOSS conference, one of the last sessions. That's the poster podium, the free paper 3 session. I welcome all the esteemed judges, Dr. Mohan Kumar, Dr. Vinuta, and Dr. Kirtana. Can you please come and grace the dais? Thank you so much.
Sorry if I... Welcome to this glaucoma session. If everybody is ready, we are already getting late. And end of the day, probably I think I'm supposed to be in all A session for the finances part. But I have been caught here. Without much delay, I think we'll first speaker... Can I get the list, ma? The first presentation will be of a comparison of retinal nerve fiber layer thickness in ocular hypertension with POAJ and normal population. Sorry, the names are not been displayed here, so sorry for that.
Can you say the name? This one more?
The second.
Good afternoon all. I'm Dr. Lakshmi. My topic for today is comparison of retinal nerve fiber layer thickness in ocular hypertension with primary open angle glaucoma and normal population. As we all know, glaucoma is a leading cause of irreversible blindness in adult population worldwide.
Just a second, excuse me. So 5 minutes allotted, so be as quick as possible. The concise things, probably with the results. Yeah. We'll be given 30 seconds.
We'll restart. You relax. We restart the time. It's fine.
Yes, ma'am. I'll start with the introduction part. As we all know, glaucoma is a leading cause of irreversible blindness in the adult population worldwide. Ocular hypertension is defined as a condition where the intraocular pressure is higher than normal, that is greater than 21 millimeter mercury, without any detectable changes in the optic nerve head or the visual field. Retinal nerve fiber layer damage is one of the earliest detectable parameters in glaucoma and may precede visual field changes by months or years. This study aims at correlating retinal nerve fiber layer thickness in ocular hypertension with primary open angle glaucoma and age-matched normals to detect early structural changes in the former, and thus we can predict the possibility of eventual glaucomatous damage and visual loss amongst the same group. Blindness resulting from POAG is largely preventable if diagnosis is made before irreparable optic nerve damage has started. So in this study, 50 eyes of ocular hypertensives and 50 eyes of primary open angle glaucoma and age-matched normals each for comparative evaluation were selected from the outpatient department between January 2023 and December 2023. Inclusion criteria: patients within the age group of 40 to 70 years, patients with an IOP of 10 to 21 mmHg, the normal group, patients with an IOP greater than 21 mmHg with no glaucomatous disc changes or visual field defects, the ocular hypertensive group, patients with an IOP of greater than 21 mmHg with open anterior chamber angle, glaucomatous disc changes and visual field defects, the POAG group. Exclusion criteria: active ocular inflammation or other intraocular diseases if present, narrow angles on gonioscopy, presence of secondary causes of IOP elevation like corticosteroid use, pseudoexfoliation, iridocyclitis, trauma, some among them, any systemic diseases influencing visual field deterioration, any corneal ectasia including keratoconus, history of any previous ocular surgeries. Result, coming to the result part, the study demonstrated statistically significant thinning of average RNFL in OHT eyes compared to age-matched normal eyes. Average RNFL thickness in primary open-angle glaucoma was found to be around 67 microns and in OHT 92 in the study. Mean superior RNFL thickness in POAG was around 80, in OHT was around 109, and in the normal group it was found to be around 121 microns. Coming to the inferior RNFL thickness in POAG around 79, OHT around 116, and the normal group 122 microns. Coming to the temporal part, primary open angle group, it was found to be 48 microns, OHT group 65 microns, and normal group 58 microns. Coming to the nasal part, POAG 60 microns, OHT 76 microns, and normal group 93. Conclusion: it is estimated that 4 to 7% of the population above 40 years of age have an IOP greater than 21 mm of mercury with open filtration angles and no detectable glaucomatous damage. These group is referred to as the ocular hypertension group, amongst which 1 in 10 is at a risk of progression to glaucoma in a span of 10 years. Blindness resulting from POAG is largely tractable if diagnosis is made before irreparable optic nerve damage has ensued. So this study demonstrated significant thinning of RNFL in OHT eyes after meticulous quantification and comparison of RNFL thickness values in OHT with POAG and age-matched normal. As RNFL loss precedes visual loss and optic nerve head defects, timely screening and routine assessment of RNFL thickness along with other parameters can aid in detection of early structural changes in ocular hypertensives that insinuate probable progression to POAG. Thank you.
What was the maximum IOP you recorded in OHT patients?
Around 28, sir. 28, 27 to
Was there any difference in the RNFL when compared with the upper limit of normal pressures with that?
Yes, sir. Around 24 to 28, it was RNFL thinning was noted more.
That you are not, did you?
Yes, sir.
Yeah. Any more? Yeah, thank
You tag a patient as OHT? What
Ma'am-
is your criteria to tag patient as OHT?
Ma'am, if a patient has more than 21 millimeter mercury of intraocular pressure, ma'am, and on gonioscopy they have open angle and they
With
have
one
no,
sitting only? With one first sitting, if it is more than 21 HT?
no, ma'am,
Repeated, right?
repeated tests. And no optic.
Constantly, generally we consider constantly, if more than 25, we consider them
Yes,
as
ma'am.
OHT.
Yes.
Do you take any measurements of the optic disc size?
CD ratio, yes, sir, I have taken.
Disc size, I'm asking.
This size I have not, sir. CD ratio I have taken.
So maybe that can also be incorporated because you
Yes,
know
sir.
that OHTs usually will have slightly larger discs
Yes,
as
sir.
compared to the thing. So that is one more thing. Maybe.
Yes, sir.
Thank you very much.
Thank you, sir. Thank you, ma'am.
The next speaker, comparing the degree of agreement of intraocular pressures in patients with keratoconus using Goldman tonometer and tonopen.
Is Atmeya here? No?
Good afternoon, everyone. My topic for today is comparing the degree of agreement of intraocular pressure in patients with keratoconus using Goldmann applanation tonometer and tonopen. Introduction. Keratoconus is a bilateral non-inflammatory axial ectasia of cornea with an incidence of approximately 2.3%, that is 2,300 per 1 lakh population. The progressive thinning of the central and paracentral cornea causes the cornea to assume the shape of a cone and subsequent biochemical alterations. Recording and monitoring of IOP is essential in patients with keratoconus. Glaucoma or ocular hypertension may coexist in these patients and following penetrating keratoplasty or refractive surgeries for keratoconus. After penetrating keratoplasty, up to 30% of patients may have raised IOP or glaucoma, risking both optic nerve damage and graft failure. It is therefore important that reliable measurement of IOP is made in these patients to assist in diagnosis and treatment. This is a prospective comparative study of total 141 patients done at a tertiary teaching hospital in patients attending outpatient department for the duration of 1 year. Our inclusion criteria: keratoconus was diagnosed based on any one of the following signs, that is Munson sign, Rizzuti sign, scissoring reflex on retinoscopy, or Fleischer's ring or Vogt striae or corneal thinning. The exclusion criteria for our study was corneal epithelial defects, scarring and edema, uveitis, uncooperative patients, or presence of nystagmus. Our results, total of 141 patients were studied, out of which 49 were males, 92 were females, and age group was between 10 to 52 years. The IOP measured with GAT and tonopen were the same. The distribution of refractive errors: 65% of the patients were emmetropic, 14% were myopic, and 12% had astigmatism. The mean flat keratometry reading was 53.18 diopter plus or minus 5.47. Mean IOP with GAT was found to be 12.06 plus or minus 2.12 millimeter of mercury, and mean IOP with the tonopen was 12 plus 34 plus or minus 1.18 millimeter of mercury. We observed that excellent agreement was found between tonopen and GAT among both cases and controls. There was poor correlation of tonopen IOP and GAT IOP with central corneal thickness in both the groups. IOP measurements with both the instruments were found to be reproducible in keratoconus as well as in normals. Discussion: glaucoma and ocular hypertension may coexist in keratoconus patients. Due to corneal changes in keratoconus, exact IOP measurements have been a challenge. Goldmann applanation tonometer, 50 years after its development, still remains the gold standard for measuring IOP and most accepted around the world. The handheld tonopen is widely available, easy to use, portable, and produces results even in the presence of corneal irregularities. The conclusion of our study is both the methods of IOP measurement with GAT as well as tonopen showed excellent agreement. IOP measured was noted to be same in both GAT and tonopen. There was no correlation of GAT and tonopen with central corneal thickness. IOP measurements with both the instruments were found to be reproducible in keratoconus as well as in normal individuals. Hence, IOP measured with GAT and tonopen are recommended as suitable methods for patients with keratoconus. It is also important to choose an instrument which is best suited for particular patient and should be consistently used for long-term follow-up. Thank you.
Did you have any problems in recording IOP in keratoconus patients? Because you have not categorized the type of cone the patient is presented in as keratoconus.
Sir, we looked at only the K reading, sir. Only the mean K reading was taken. Based on that, we had taken the.
I do agree that, but because did you have any problems in recording IOP in keratoconus patients? because you have not categorized the type of cone the patient is presented in as keratoconus.
We looked at only the K reading, sir. Only the mean K reading was taken. Based on that, we had taken the.
No, I do agree that, but because it's not that, because the Myers, whatever you get on keratoconus cornea is like totally different from that any normal aspheric cornea.
Myers
So I'm just asking, was there any, because you have not
mentioned.
categorized the type of keratoconus what you have done. So I don't know, maybe with based on K reading, how did you
Based on the K reading, only the both GAT and tonopen we had checked, sir.
the tonopen is okay, but I'm just talking about the Goldman applanation, because applanating surface, you may not get a perfect
Myers.
the end point of estimation if the cones are totally different.
Yes, sir.
So there are all the additional things. So that's one thing.
Keratoconus patients, which you have included in your study, is it status post C3R or no
ma'am,
procedure has
no
been
procedure has been done for these
done?
patients.
Without any strengthening
any
procedure. But that matters for your follow-ups, right?
Yes, ma'am.
How
After
to-
penetrating keratoplasty, also we have to check their IOP and.
Yeah.
Yes, ma'am.
So I think post C3R would be a better idea, I guess, sir.
The other thing is you have not mentioned about the CCT. That also plays a role, because in keratoconus there could be variation in the thickness also. And thickness, you know that it's going to alter the measurement of intraocular pressure as well. So these are two pitfalls what you need to look into before you take up this study. Thank you. Fourth person is not there. So the balancing a double-edged sword, exploring steroid-induced glaucoma in a tertiary care eye center perspective.
Good afternoon, all. Myself, Dr. Drishya Sudev, and the topic of my presentation is Balancing a Double-Edged Sword, Exploring Steroid-Induced Glaucoma in a Tertiary Eye Care Perspective. As we all know, steroids are known to induce ocular hypertension when administered with topical, periocular, and even systemic or inhalational routes. Nearly 30 to 40% of all normal adults and almost all primary open-angle glaucoma patients are steroid responders, demonstrating clinically significant elevated IOP following corticosteroid use. Also, one matter of major concern is that in India, ophthalmic steroids are easily available without prescription and are self-administered by persons who are not aware of their potentially catastrophic adverse effects. Steroid-induced glaucoma has an important social impact because it is often diagnosed after significant damage has already occurred in both adults and children. Our study was a hospital-based prospective observational study conducted in a tertiary eye care center in South India. Patients who met inclusion criteria were enrolled for the study. Visual acuity assessment, slit lamp examination, IOP measurement using Goldman applanation tonometer, gonioscopy, fundus evaluation using 90D were done from at presentation after 1 month and after 3 months. A total of 75 eyes of 43 patients were enrolled in the study, of which 8 patients had unilateral manifestation and 35 patients had bilateral manifestation. The mean age of presentation was 34.74 years. Mean IOP at presentation was 30.18 millimeters of mercury. Our youngest patient was of 4 years of age and oldest patient was of 74 years of age. We had a total of 43 patients, among which 28 patients were male and 13 patients were females. And the visual acuity at presentation was 6.6 to 6.36 for 52 patients. The routes of administration of steroid, which we encountered were these, and the most common one was topical eye drops, which was 53.48%, followed by oral, which was 18.60%, and intravitreal, which was 16.27%. Other routes which we saw were supratarsal steroid injection, inhalational route and via skin ointment. The commonest eye drops which was involved in the development of steroid-induced glaucoma was prednisolone acetate 1%, and there were 13%. Among 7 patients were vernal keratoconjunctivitis patients, and other 4 were keratoconus patients status post C3R who were on steroids. The duration of usage at presentation which we encountered the most was about 2 to 6 months. And we had patients up to, who used steroids for a larger duration, like around 5 years also. So the mean IOP at presentation was 38.47 millimeters of mercury. At 1 month, it was 20.03 millimeters of mercury, and at 3 months, it was 17.33 millimeters of mercury. A total of 12%, that is 9 patients underwent surgical management. At presentation, one patient each underwent trabeculectomy and cataract surgery with trabeculectomy. At 1 month, 1 patient underwent trab, and two patients underwent cataract surgery with trabeculectomy. And at 3 months, 3 patients underwent trabeculectomy, and 1 patient underwent cataract surgery with trabeculectomy. So in our study, the male to female ratio was absorbed to be 1.86. We had a varied age distribution as mentioned earlier. 30.23% patients developed steroid-induced glaucoma secondary to self-medication. Most common route of administration was found to be topical eye drops. 69.33% eyes had visual acuity better than 636 at presentation. 12% patients required surgical management for control of IOP. This study aims to describe the pathophysiology and epidemiology of steroid-induced glaucoma and principles of management in a tertiary eye care perspective. Steroid-induced glaucoma adds significant morbidity to the population, but it can be controlled effectively with proper patient education across multiple medical specialties. Medical professionals also need to be sensitized regarding the potential risks, red flags, follow-up protocols, and timely referrals concerned to steroid-induced glaucoma to prevent irreversible blindness. Thank you.
In the number of patients, 12 patients you operated, what was the duration of glaucoma? Duration of glaucoma or steroid intake with glaucoma? I want the duration, time frame. Because surgical patients you said, say, when just merely you showed 1 week, then 1 month, and so on. So. No, I saw there, but still, in those surgical patients you have operated.
Sir, one patient which we operated, so he presented both eyes 0.9 advanced cupping after 3 years of clobetasol usage. Some patients, after 3 months of follow-up, when they were not, like IOP was not controlling with medical management, we planned for surgery.
No, it means that longer duration was the cases to be taken into account. Why I'm just telling is probably if it's a small duration, still a patient can be a steroid responder. So that's one way of.
Least was 1 week also we had a small kid, sir, known case of VKC. On prednisolone, she developed a response.
1 week.
1 week with cupping also. Glaucomatous changes.
Cupping. Child. What's the age of the child?
7 years.
7 years.
Particular patients with whom you have operated, whether they have been given maximum medical therapy already, it is not been controlled IOP, then you planned surgery. Okay.
So the unveiling of secondary glaucoma insights from a tertiary eye care center. Next speaker.
Good evening, I'm Dr. Saidira M. So, glaucoma is the leading cause of irreversible blindness. While the prevalence and morbidity of primary glaucomas has been pretty well established, being in the West as well as in the developing nations, there's very little information regarding secondary glaucomas, especially considering their varied profile due to various factors like educational, economical, social, cultural, awareness among patients, lack of ophthalmic services, or access to ophthalmic services, life expectancy, and also improvement in current surgical practices, there has been a constant change in the profile of secondary glaucomas, not only over region, but also over time. With this main objective as in our study, we decided to go ahead with this study in our hospital. So it was a hospital-based cross-sectional study performed over a period of 6 months, from 1st December 2023 to 31st May 2024. Patients presenting to our glaucoma clinic who underwent detailed ocular history and ophthalmic examination, and those diagnosed as secondary glaucoma were included. So coming to the results, out of 8,034 patients presenting to the glaucoma clinic, 524 eyes of 418 patients, that is 6.5%, had been diagnosed with secondary glaucoma. The mean age at presentation was 50 years, and the male to female ratio was 1.8:1. At presentation, the average IOP was 35 mm Hg. Defective vision was the most frequent presenting complaint, with open angle glaucoma being the most common subtype, that is about 61.6%. No light perception was found in 65 of our patients, that accounts to 13%, and a visual acuity of less than 3/60 was seen in 49% of our patients. On disc evaluation, advanced cupping was seen in 117 of our patients, with glaucomatous optic atrophy in 50 of them. Among the various diagnoses of secondary glaucoma, in our study, pseudoexfoliative glaucoma constituted about 23% of the population, that is 121 patients, closely being followed up by neovascular glaucoma and steroid-induced glaucoma, which accounted for 20% and 19.5%. The remaining glaucomas were inflammatory and uveitic, silicon-induced, lens-induced, and post-traumatic. On further evaluation, we noticed that in the elderly population, that is patients aged above 60 years, pseudoexfoliative glaucoma was the most common type of glaucoma, whereas in the younger population, aged less than 40 years, steroid-induced glaucoma constituted about 32.5% of glaucomas. Coming to the management, 68 patients, that is about 13% of our patients, required surgical intervention in the form of either combined cataract with trabeculectomy surgery or cataract surgery with surgical peripheral iridectomy. And among the medically managed patients, 23 patients required intravenous mannitol, and 3 or more AGMs were instilled in 39 of our patients. So in our study, we found a male preponderance. Almost 2/3 of our patients presented with poor visual acuity. 1/3 of our patients presented with advanced cupping and glaucomatous optic atrophy, and 90% of these patients were treated medically. So pseudoexfoliative glaucoma was the most common cause in our study, stressing the importance of regular screening in elderly population to prevent increased visual morbidity. And neovascular glaucoma and steroid-induced glaucoma were the next leading causes in our population. So both having preventable etiologies, it warrants a closer look at current practices. High index of suspicion among all ophthalmologists, meticulous screening and timely intervention can definitely help decrease the burden of secondary glaucoma in our population. So regular survey and profile of secondary glaucoma should be conducted to identify any changing patterns in their etiologies. Thank you.
You did mention about 8,034 patients in 6 months.
Yes, sir.
That comes to around, you have 4 days of glaucoma clinic.
No, sir. We are having 6 days of glaucoma clinic.
All 6 days?
Yes, sir.
Okay. Then it's fine. So otherwise, because in a matter of 6 months, getting so much of glaucoma patients,
No, sir. We have 6
it's
days.
humanly impossible, because the overall incidence of glaucoma per se in general population is 4 to 5%.
Sir, there are patients presenting to the glaucoma clinic, sir. So there are cases of
No, I do agree.
suspects
What
and,
is the normal general patient load per day?
yes, sir.
An outpatient, how much?
So 500 to 5.
Exactly, because I am from Bangalore Medical College. Way
Yes,
back
sir.
in
Yes, sir.
1989, it's at 1994, and all. Then itself we were having around 200, 300 patients. But still, considering the overall the OPD attendance, in that, how many glaucoma patients you can still end up? That's my question. Of course, pseudoexfoliation is the most common entity we come across in anything. So maybe, I don't know, that was a little doubtful from my end.
Sir, we have about 80 to 90 patients presenting to the glaucoma clinic per day, which is a full working day, so from 9 to 4. And on the other days, which will be probably half days or so, at least 40 to 50. So considering that we have 500 patients per week, and 8,034 patients include DIS suspects, glaucoma, because all the patients refer to the glaucoma.
Yeah,
service.
yeah, any
It's an
small
overall picture.
suspects are done.
Yes, sir.
Now, my concern was like you projected so many secondary glaucomas.
Yes, sir.
So that's the thing. There was some either was there any confusion in that statistics or something like that?
No, sir. It is 524 eyes or 418
Did you
patients.
use MMC in all cases of pseudoexfoliation?
Yes, sir. Pseudoexfoliation for the surgery with trabeculectomy.
Yeah.
We use mitomycin C of 0.02% for 2 minutes, sir.
All cases.
Yes, sir.
What about neovascular glaucoma?
So neovascular glaucoma, in our study, we had only one case that was operated, and that too, it was already a repeat surgery, already operated. So that patient underwent again with mitomycin C.
Did
It was
you
a repeat
do any pre-op monitoring of this patient in neovascular glaucoma? One patient you operated.
Yes, sir.
What was it done?
Sorry, sir. I didn't get it.
Pre-op assessment and any care that was given.
Sir, anti-VEGF was given intravitreally 48 hours before the surgery
Okay, right.
to decrease hypoxic insult.
So all cases were new cases or new and old cases?
Sir, ma'am, it included new and some cases which were treated outside and referred to our hospital. So they are presenting to our hospital for the first time.
I think especially in neovascular glaucoma cases, there is a chance of high failure rates.
Yes, ma'am.
So post-trap.
Yes,
So already failed trap you said, one
Yes,
case.
ma'am,
So
one
better
case.
to do valve, I guess, in such cases rather
Yes,
than retrap.
Yes, ma'am.
Thank you.
Thank you, sir.
So the next speaker will be wipeout syndrome, relic of the past, a relevant risk in advanced glaucoma surgery.
Very good evening, everyone. Today I'll be talking about wipeout syndrome. Is it a relic of the past or still a relevant risk in advanced glaucoma surgery? Now, this, according to me, is a very important discussion because management of glaucoma patients with advanced glaucoma, as many of them present in this condition to our clinics, is very challenging because of the dreaded wipeout syndrome which we think about. Wipeout syndrome, which is also known as Snafford phenomena, refers to the unexplained and permanent severe loss of central vision after filtering surgery. So our study aimed to evaluate the outcome of surgical treatment in advanced glaucoma. It was a retrospective study where we reviewed the records of 31 patients, 45 eyes of those who underwent glaucoma surgery. Inclusion criteria included all the patients with end stage of the disease who were not being controlled by maximal medical therapy, and we excluded those cases where the vision loss could be contributed to some other ocular pathology. The cutoff period we took for our follow-up was 6 months, and we carried out statistical analysis. So the baseline parameters, there was age 47 years with a wide gap, 20 years plus or minus, equal 15 and 16 male-female ratio. Most common type of cases on which we operated was primary open angle followed by primary angle closure. So there was no statistical significance in the visual acuity, but there was statistical significance in reduction of IOP from 32 to an average of 14, and thereby the number of anti-glaucoma medications used also reduced from 3 to 1. What we also observed is that there were no reported cases of wipeout syndrome within the 6-month follow-up period. So our study is also similar to other studies, where a study in 2019 by Igor et al. Also showed that there is significant reduction of IOP, achieving the target in advanced cases with no wipeout reported. In a study by Theodoros et al. In 2023, they have also reported that the target IOP has been achieved in advanced glaucoma cases and no wipeout reported, and similar results have been reported by Balekadaru et al. In 2014. When we compare this to the older studies, such as the study in 1977 by Kohler et al., where out of 103 eyes which they studied, they reported 5 cases of wipeout syndrome. And a 1986 study by Dr. Agarwal et al. Had reported 6 cases of wipeout study. But on further literature review, what we found that these older reports showed higher incidence of wipeout because one reason could be that there was insufficient technology to accurately detect the causes of visual loss. So possibly it is mislabeled as wipeout syndrome. So what we concluded from our study was that we should not defer surgery for advanced glaucoma patients just because of the fear of wipeout syndrome. It definitely has a beneficial effect, and the reported causes of central vision loss were clearly identifiable causes, most commonly macular edema, hypertony associated macular ischemia, and uveitis. So in order to preserve the residual vision, surgery should be considered. So what I learned seeing my seniors and stalwarts of glaucoma practicing is that they convince and they tell the patient that if you do not get operated, you will definitely lose your eyes. And so how they tell that to the patient is that if we don't operate on you, definitely you will lose the eyes. But if we operate on you, there is a chance you will regain the vision. As beginners or beginning practitioners, we need to take a second opinion when we are operating on such eyes, and always it is better to under-promise and over-deliver in such cases. One of the limitations in my study was we need to do a longer time of record reviewing, and the sample size is quite small because as it's a smaller sample size, possibly the less than 1% risk of wipeout could be have missed. So final take-home point would be that this wipeout is a diagnosis of elimination, and it is not a reason to delay surgery. These are my references. Thank you.
Can I just know what was the optic disc changes that had happened in all those cases being operated? Average.
Sir, the average, we have taken it as advanced glaucoma from 0.8 onwards, sir. 0.8, 0.85. Because in the case sheets I have analyzed, wherever it is written CDR as 0.85 and diagnosed as POAG or PACG with advanced GOA, and those cases which have been operated, from MRD I have collected those reports.
So the point is, the take-home message is, of course, we can still not rule out this Snufford phenomena because these are the ones which happen in advanced glaucomatous. Advanced glaucoma, that means to the extent that almost they are coming very close to the near total coming, but still some patients will have 612, 6/9 visual acuity, where they may be having still central 5-degree vision, 5 degrees, in that too, one or two quadrants would have lost. Probably, I think if you do a macular program or something like that, so that will give an accurate assessment of the macula before you proceed with the surgery. So I'm 100% sure that probably even if there is out of 4 quadrants, even if 2 quadrants are gone in that whatever macular program you do, and there are every chance. I'm just trying to tell that if more advanced, 0.85, 0.8, 0.9, all that and all is not a problem. I think still surgery to be advised in such patients. And we know that the ischemia is one of the component in glaucoma that is still persisting. And of course, still both are blind, as the patient as well as the surgeons are blind as of now, with the advancing technologies also. So the message is that you have to be aggressive, but at the same time, when you come across a very long standing means almost you can see there no probably a proper rim of NRR that is seen, but still patient can see some vision. So those are some of the cases clinically what you can think of. They are the ones which may go in for. And when you just do an RNFL, I think even what you have, the double hump sign, whatever it is, every line that it is crossed into the red one. So probably they are the ones who are high risk of losing. But definitely even in my experience of last more than 27 years, I have not come across a single case of snuff out as well. But still, but that elimination cannot be excluded because you saw the previous studies which were all given, so 5 or 6 cases, that less in number, but still. That significant, and ischemia is one component we need to always keep in mind. And these eyes are more prone, even the fluctuations of intraocular pressure, whatever you do when you are performing surgery itself is more than sufficient to induce the damage to the existing neurons. It's a neuropraxia which happens in most of the surgeries, but definitely neuronal death occurs in such vulnerable eyes which are already compromised there.
How many of your patients had macular split? The patients which you have operated?
Yes, ma'am. That was one of the limitations in my study because for some patients, lot of the cases it has been the visual fields are not reliable.
Not
ma'am. So
documented,
that is why I did not take it as a key parameter in the study.
That's the, I think, more important, as Sir said.
So
Yes.
It is something which is done and then.
we have collected the data, ma'am.
Okay, like a retrospective.
Yes, ma'am. Retrospective.
Thank you. Now we'll go on to the neuro-ophthalmology and trauma session. The first speaker for the day. Unusual presentation of sidrosis. Somebody has left this star. I think Kavita left here. The previous speaker. Anybody wants water? Somebody.
Good evening, all. Good evening, all. This is just a case of sidrosis with little unusual findings. So he was an 18-year-old boy with an injury with metallic foreign body just 45 days back, and he noticed to decrease vision since 15 days. So on the slit lamp you can see there's an entry wound here which is still not sealed up, and he has already developed pigments on the anterior capsule, and the other iris have not captured the data, but his this iris was little more hyperpigmented than the other iris, and all the cornea had all these granules also studded all over the deep stroma. And on the X-ray we could see there was a long foreign body here, and which was confirmed on the CT also. So we went ahead with the surgery. After a good Corvit, we extended the right hand port, went in with the max grip, and I didn't want to because his vision was 6/9, so I didn't want to sacrifice the lens, so just could pluck it from internal only. Didn't want to go from external and extend the wound and cause more bleeding at that ciliary body area, and I could remove the foreign body without causing a lens touch. So in toto we could remove it from the opposite side, and it was around 4 to 5 mm, and then we did cryo to that area where it had hit, and we sutured the external wound. So he then over 8 months follow-up, his vision did decrease to 624 because his cataract had extended, progressed, and his IOP was still maintaining at 14. It had not decreased, and his fairness was essentially normal with the RP mottling at the nasal quadrant. We did advise ERG for him this time, and we wanted to know how much his retina is like damaged, and he had then we had planning a cataract with IOL explantation. So in the discussion, I just want to say that this metallic foreign body presented very early to us, as with sidrosis. So he had metallic foreign body which was probably very long, thin, so it had not got any encapsulation. So probably it released so much ions, and it was sitting in the ciliary body. So he had more anterior segment findings than posterior segment, and fundus was essentially normal initially, though we did not do an ERG. And he had a very early presentation. So frank sidrosis at 45 days is quite rare. So the earliest report is only at 18 days. So ours was a little earlier. Yeah, thank you.
Just other than the deposit, what you saw on the lens?
Yes.
Because you said it's sitting on the ciliary body. Did you take ASOCT?
No, sir. But I mean, we could have. I mean, the cornea. We tried a slit photo, but we could not capture those iron, those brown granules all studded in the cornea.
Okay. Probably, I think 8 months down the line, follow-up his visual acuity is 6 to 1. What is the grade of cataract?
Maybe NS2, PSC, and also ASC, the anterior subcapsular also.
Okay.
Progressed.
So maybe I think ERG is still.
Yeah. I think
it has to be.
the amount of ions that are released first will be enough to progress the disease, even though I have removed the foreign body.
So the earliest is 18 days. What you in your case?
Yeah, in our case 45.
45 days. Okay. Thank you.
Thank you.
The next person would be in the blink of an eye, atypical presentation of idiopathic intracranial hypertension. Unlocking the complexities of ocular trauma, a visual journey through diagnosis and treatment.
Good afternoon, everyone. Unlocking the complexities of ocular trauma, a visual journey through diagnosis and treatment. Ocular trauma is one of the common causes of acquired blindness. The severity of ocular trauma can range from minor to severe, potentially leading to permanent blindness and visual handicap. Eye injuries measure about 8 to 14% of total injuries. Methods. This is an observational study including 50 patients done at tertiary teaching hospital in patients attending outpatient department and also casualty during 1 year. Inclusion criteria was age group between 20 to 45 years and patients with history of trauma. Exclusion criteria was pediatric age group, that is less than 20 years or more than 45 years. Methodology, detailed clinical history was taken, routine ophthalmic examination starting from vision assessment using Snellen's chart, and detailed anterior segment evaluation was done using slit lamp biomicroscope. A detailed fundus examination was done by 90D lens and 20D lens. IOP measurements by Goldman apparition tonometer or non-contact tonometer. B-scan was done in eyes with hazy media. CT and MRI was done in necessary patients, and OCT was also done. General physical examination, past history, family history, history of any systemic diseases were also taken. Patients were treated accordingly and the visual outcome was noted. Results. In our study, blunt trauma is the most common type of ocular trauma with better visual prognosis compared to patients with open globe injuries who had bad visual prognosis, and increased incidence was seen among males. 76% of study population showed blunt trauma. 60% belonged to the age group of 20 to 30 years, and 64% of them were closed globe injuries, and 36% were open globe injuries, of which a majority were corneal perforation. 61% were corneal perforation. Most common mode of injury was road traffic accident, which accounted to 23.8%. And in closed globe injuries, majority, that is 59%, had ocular trauma score of 5 and visual outcome with visual acuity of more than 6/12. Discussion. For globe rupture, emergency department treatment includes supportive measures to prevent worsening of injury or extrusion of intraocular contents. Hence, antiemetics should be provided to prevent Valsalva from vomiting, leading to increased intraocular pressures and subsequent loss of aqueous fluid. Analgesia should be provided as needed. A rigid eye shield should be placed and additional manipulation of the eye should be avoided. The patient should be placed in semi-recumbent position. Prognosis depends heavily on the sequelae of trauma. Prevention is also the key, and measures such as wearing protective eyewear during sports or hazardous activities, handling chemicals with caution, and ensuring proper safety protocols in the workplace can help reduce the risk of ocular trauma. Conclusion of this study: ocular trauma poses a substantial risk of visual health and requires prompt recognition, appropriate management, and comprehensive rehabilitation to minimize long-term sequelae. By understanding the epidemiology, types, clinical presentation, management strategies, we can improve the outcome and enhance the patient quality of life. Thank you.
What was the duration of the study you have done here, ocular trauma?
Sir, 6 months, sir.
6 months.
Yes,
But
sir.
61% of the corneal involvement, corneal perforations.
Sir, open globe injuries were less
No,
compared
I
to
don't
the
know.
blunt trauma, but among the open globe injuries, majority were.
61% had corneal perforations, you mean?
Yes, sir. Among the open globe
I know,
injuries.
open globe injuries.
Yes, sir.
What was the degree of injuries you have noted there?
Superficial.
Corneal perforation you are talking about, no?
Yes, sir.
Yeah, that's what I'm asking. What was the extent of injury that these patients had? I just want to know that.
Sir, mid-stromal injuries.
Then how did you
Not-
call it as perforation? Through and through.
Okay.
No, I
more
just
like
wanted to
corneal
know, like
laceration.
basically you are telling,
I think it more like corneal laceration
then
instead
it doesn't
of
fit into your
perforation.
corneal perforation. It's still a closed globe injury. It's just a laceration.
Laceration.
No,
It's
I just
not-
want to
No,
know.
sir, it is laceration. I think I've mentioned it wrong, saying
61%
perforation.
of 36 means it's around of perforation. And what was the degree of injury?
No, sir, not
such patient?
perforation. Instead of laceration, I think I've mentioned it as perforation.
Then, because only a blunt trauma only, no? Then.
Blunt trauma, majority of them had, sir.
No,
all the
even
patients.
these also fit into blunt trauma only, because you're not telling the it is in the midst trauma or something like that. You got my question, what I'm asking?
Yes, sir.
Yeah. Oh, I'm not confused. Are you trying to confuse me?
No, sir. You asked if it is corneal perforation, then it should
No,
be. a
not
blunt
asked.
trauma.
You have mentioned there it is corneal perforation.
Yes, sir.
Perforating injuries. Corneal per se was about 61%. What you have mentioned there.
Yes, sir.
Go back. What's taken out? It's okay. Early bit. No, you got my point. What I'm trying to tell. I'm not telling from my side. What has come up there, I'm just trying to ask you, what was the degree of injury in those corneal perforations? But you are telling it's just a superficial laceration and abrasion, something like that. So that doesn't fit into perforation at all.
Okay,
Probably I
sir,
think you need to read that.
Okay. Thank you, sir.
Emergent cerebral venous sinus stenting for acute visual loss in fulminant idiopathic intracranial hypertension. A case report.
Good evening, one and all. My topic is cerebral venous. My topic is cerebral venous sinus stenting in a treatment of fulminant idiopathic intracranial hypertension. IIH, also known as idiopathic intracranial hypertension, commonly present in women of childbearing age with a myriad of symptoms including intractable headaches, progressive vision loss, and tinnitus due to elevated cerebral spinal fluid pressure. If left untreated, chronic progressive optic atrophy and visual impairment may occur, sometimes resulting in permanent blindness. An acute fulminant term, fulminant IIH, present with an acute rapidly progressive loss of lens acuity and central visual field loss. We report a case of fulminant IIH who was successfully managed with dural venous sinus stenting. Case details: 20-year-old female who sought treatment for severe headache, vomiting, and blurring of vision of 2 weeks duration. Onset of headache and vomiting was sudden and progressive. Associated blurring of vision started 2 days after onset of headache and vomiting. There is a history of recent weight gain of 3 kilograms, and patient was not any medication that is known to cause IIH. The details of the patient: visual acuity is 6.6 in the right eye and 6.9 in the left eye, with a deficit of color vision of red green, and there is a pupils of 4 mm ill sustained in both eyes. Fundoscopy shows severe papilledema of Frison's grade 4. Visual fields: there is a construction of the nasal fields with enlarged blind spot. B-scan USC showed 6.27 and 5.91 in the right and left eye respectively. MRI with contrast and NMRV showed toxicity of bilateral optic nerve, flattening of the posterior sclera, stenosis of bilateral transverse sinus with no evidence of thrombosis. CSF analysis showed a CSF opening pressure of 530 mm water. There is no cells and proteins with 16.4 mg per dl and glucose 70 mg per dl. This is a fundus pic showing the patient, which is showing a Frison's grade for papilledema. Investigation showed a toxicity of bilateral optic nerves as shown in the figure. These are the investigations further done, that's B-scan, ONST and perimetry. Further, the patient was administered IV mannitol and oral acetaminophen maximum dose. As the visual acuity remained reduced on 7 post-admission day, patient underwent transcutaneous cerebral venous sinus stenting. The procedure was uneventful. On the third procedure day, there was an improvement in visual acuity and symptomatic relief of the headache. There was an accompanying reduction in the papilledema grade. At 15 days follow-up, patient is asymptomatic. This is the treatment outcome, which shows the perimetry pre and post. This is a fundus diagram which shows the grade for papilledema in the right and left eye with B-scan ONST values of 6.27 and 5.91. Post-procedure, the patient showed a significant reduction in the disc edema with a B-scan value of 5.3 and 4.8. The review of literature. The management of IIH is medical and includes ICP lowering agents along with measures for weight reduction, which includes oral acetaminophen being the mainstay. Surgical procedures like optic nerve sheath fenestration, CSF shunting procedure, and cerebral venous sinus stenting are reserved for the treatment of visual loss in IIH. Cerebral venous stenting is a relatively newer procedure for visual field loss in IIH. It has been increasingly done for chronic progressive loss of vision in IIH. There are reports of venous sinus stenting performed in patients with fulminant IIH with good outcomes as seen in our patient. Going to clinical implications, fulminant IIH is a non-entity with reports of irreversible vision loss when treatment is delayed. Early diagnosis and medical treatment followed by surgical treatment is mandatory to prevent irreversible vision loss. This report highlights efficacy of venous sinus stenting in the treatment of fulminant IIH. Thank you.
First thing is good history collection, all that thing is fine. My question is, you said sudden some severe visual loss, but when you look at the visual acuity, patient had 6.9 in one eye and 6.6 in the other eye.
Yes, sir. That was visual. There was a blurring. It's not actually visual loss. Blurring only was the patient.
And where did the patient land? Did she come to ophthalmo OPD or?
She came to ophthalmo OPD directly.
Or it was a referral from neuro center?
No,
or,
we referred them to neurosurgery, sir.
Okay.
Neurology, basically neurology OPD.
And MRI, everything was taken
Everything
there?
was done, sir.
Done
MRI,
there?
Done by the neurology department.
Okay. The point here is probably I think
They admitted the patient, sir. They admitted the patient. After MRI, MRV, they admitted
what
the
was the
patient.
CSF pressure? Is there any documentation of CSF
Yes, sir,
pressure?
it's there. 530 millimeter
530?
watt.
Okay. That's fine.
So
Why-
they admitted, sir. They admitted the patient.
Why did you coin the term fulminant here in this particular patient?
Sir, why I called it fulminant? Because even if after the patient was a very young patient, young girl, and the patient complains of blurring of vision, then the B-scan ONSD was like 6.27 that much, and even after giving oral acetaminophen maximum dose, patient was not responding. So usually IIH will respond with oral acetaminophen maximum dose, acetaminophen maximum dose, but even after giving that, the patient was not responding. So this is the case of patients. Even life is saved by the pause of this stenting procedure.
Yeah, I do agree. Probably see the IAH secondary to the venous sinus involvement here. Of course, for the patient it's an emergency, but in such case of intractable headache and such thing, so much more catastrophic events in the form of SH, subarachnoid
yes,
bleed.
subarachnoid
Bleed is the one which has to be considered as a first event. That because you can get papilledema as a manifestation of any ICSOL or even an acute bleed, more so of a subarachnoid bleed.
Okay.
So still I have a doubt as regards to that fulminant IH, something like that. Probably the venous sinus which was there of a long-standing chronic.
Sinus stenting was
the
done,
chronic.
sir.
The
Correct,
chronic disease persisted and suddenly it has just come to an ophthalmic department. So that's what I would like to put it, rather than, because she may be having blurring of it, because the vision usually doesn't be lost, because I have series of patients for more than decade, 2 decades.
Okay.
If somebody, another ophthalmologist see for the first time 100% CT, MRI, everything will be done.
Okay.
But that patient is with me with absolutely no loss of vision or something like that. As far as IAH is concerned, intracranial hypertension, they do well. only the dietary lifestyles and other things are to be carried up on. That's
This
it.
patient was also advised to reduce the weight.
No, that's all there. No,
Yeah.
my thing is it is something to do that this lady must be having an intracranial pathology for a very long time, and that just that she has presented to the thing. Probably a further follow-up, I think. Usually, invariably, the IAH patient, the disc edema and all will never subside completely. Will never subside. It will be persistent throughout. Because I've been following up many patients and they're still having papilledema. It doesn't go at all. I think you'll be getting that patient back again and again. If the edema disappears, then it is not secondary to IAH. It is with the venous sinus itself.
Okay.
So that's the thing, because it's a case report you have just presented here.
Yes,
So
sir.
need to for a very good follow-up of this patient.
Okay,
Thank
sir.
you.
Thank you.
I think.
Other studies, how many days you want to try the medication and when to intervene? surgically?
This patient we started and we observed, ma'am. After first day, third day we observed, but still the patient's symptoms like that headache was there. And after that we waited for 7 days. After 7 days, intervention radiologist told and neurologist discussed together and told we'll assisting girl also to for that we'll go for a cerebral transverse sinus stenting with it. Then the short GA. Yes, sir, ma'am. They are also saying the same. Because considering the age, if it is a little, it's usually seen in this age only, but if you're considering age and any progression of symptoms or if she's reducing any reduction in symptom, definitely we would have considered Dimox for a longer time.
Thank you. Next is yours only. Oh, you are in line. Finish completely. Last, evaluation of various ocular manifestations, ICS.
No, sir.
Acha, other two are not there with me. Acha, thank you. Thank you. But still, I think it's over. I think they're downstairs. Traumatic globe relaxation case series.
Good evening, everyone. The topic today which I want to present is traumatic globe luxation, a case series. Ocular trauma is the commonest cause for ocular morbidities leading to visual disability and blindness worldwide. 2.4% of total blindness is caused due to trauma. So what is luxation? Angular displacement of the equator of the globe beyond the palpebral fissure. It's a rare occurrence secondary to blunt force, associated with orbital wall and facial bone fracture. And there is always an associated with a risk of permanent visual loss. Aim is to describe the clinical presentation, visual outcome and management of traumatic globe luxation. Methodology is a retrospective case series. Study period is from July 2023 to May 2024. Inclusion criteria, all patients with globe luxation who presented to emergency from July 2023 to May 2024. There is exclusion criteria is nil. 40-year-old case 1, 40-year-old female with history of assault with wooden stick presented to ER, and on examination right eye was within normal limits, left eye visual acuity was PL negative, sutured lacerated wound over the forehead extending to the left eyebrow. She was referred from an outside hospital after the primary treatment. Globe luxation noted with later retracted. Subconjunctival hemorrhage with diffuse conjunctival congestion. Cornea is hazy, extraocular movements are limited. Lens details are not visualized and fundus no view. This is a POD 1 of the patient. Case 2. 22-year-old male presented with history of RPA on examination, left eye within normal limits, right eye. There is a deep laceration above and parallel to the right eyebrow. Globe luxation with conjunctival chemosis and dense subconjunctival hemorrhage. Cornea is hazy, lustrous, stromal edema. Hyphema was present in the AC. Pupil and lens could not be assessed. Case 3. 26-year-old male with history of RTA presented to the emergency. On examination, left eye there was no perception of light. There is a deep lacerated wound measuring 12 into 5 into 3 cm extending from the eyelid to the forehead medially. Luxated globe with dense subconjunctival hemorrhage and chemosis. Cornea is hazy and edematous and limitation of extraocular movements were there. Case 4. 18-year-old young male presented with history of trauma by shrapnel secondary to blast in workplace. On examination, left eye was a deep laceration in the frontal area with extensive soft tissue loss. There was a globe luxation with subconjunctival hemorrhage and chemosis conjunctiva noted. Cornea is hazy with stromal edema. Demography. Age was ranged from 20 to 54 years. Male to female was 3:1. Cause of luxation was trauma in all cases and presenting visual acuity was nil perception of light in all cases. This was ocular findings of this patient's. Case 1 had lens dislocation, extraocular globe laceration as well as optic nerve avulsion. Case 2 have lens dislocation as well as optic globe laceration. Case 3 optic nerve avulsion, extraocular movements avulsion as well as globe laceration. And the case 4 optic nerve avulsion, globe laceration and lens dislocation was there. Results: all globe luxation was secondary to trauma. Visual acuity at presentation was nil perception of light. Patient remained real negative after 3 months follow-up. Ocular findings: 2 cases had retrobulbar hemorrhage, 2 had lens dislocation, 50% had EOM avulsion, and 25% had optic nerve avulsion, and 75% had orbital bone fracture. All 4 developed isis bulbi at 3 months follow-up. Discussion: Bruno et al. Studied 34 patients with traumatic globe luxation, of which 73.5% of patients underwent globe repositioning, and for us enucleation was done. Our study all underwent globe repositioning. Other published case reports by Sandy et al. And Mohapatre had similar findings as in ours. Despite globe reposition, patients developed isis bulbi. Our study reported optic nerve avulsion as one of the most serious complications of traumatic globe. Reposition of the globe was a first-line management in our study. Conclusion: globe luxation dramatic clinical presentation with a devastating outcome to a blunt trauma. Globe preservation is preferred irrespective of visual prognosis. Grey visual prognosis should be explained in the case of traumatic globe luxation of the globe. This is a Guinness World Book recorder with a voluntary globe luxation. Thank you.
Of course, very severe. She has pointed out about 4 cases, not total. So 4 case series, but still many of the times, especially severe road traffic accidents and all, they end up in having this sort of luxation. And the picture what she is depicting probably I think is an habitual person coming out with Javed Jafri style.
Yeah.
But otherwise, even one thing you need to remember is especially these animal attacks, especially the bear or people going to hilly areas, something like that. So they are the ones where the nail of the bear is so big enough, and then just one punch can completely luxate the globe and then come out. I personally seen 2 cases probably when I was doing my post-graduation at KMC Hubli. So we had 2 cases coming out like that. Of course, that's one more thing like probably. Otherwise, by and large, globe luxation most of the times. Thyroid, extreme degree of thyroid cases very, very, very rare.
And spontaneous also.
Yeah,
sir.
spontaneous, floppy eyelids,
Rosen syndrome, all these can also present with globe luxation.
Yeah, it's there, but still, whatever think of it, Crossens as such per se, anyway, it's a defect in the orbit itself. So it's nothing to do with the luxation. The orbit itself is very, very shallow in that case by birth. So that's all.
Thank you, sir.
Yeah.
Ma'am, all cases we did
retrospective. These are all retrospective studies with the color. Duration.
What, ma'am? Duration of the study?
And yeah, means retrospective over how many years?
In the ma'am, 1 year only, ma'am. 1 year we got 4 cases of
1 year you got 4.
Yeah, 4 cases of globe
This is here, right?
Yeah.
St. John's.
Yeah.
Oh, that's very common, right? Then
1 year we got this much cases.
RTAs are more common. Oh. This is a highway road, Vasur highway connecting. No? So I think they get a lot of case referrals.
More cases will be referred from Krishnagiri, Anantapur.
So otherwise, it's not very common.
Yeah.
It's a little.
Yeah, that's what. RTAs wherever the medical colleges are on national highway. No? So we do come across like that, and probably I think, as I said, any forest areas in and around. So people, local people, they go for livelihood. Suddenly some animal attacks, and that's or sudden they might fall against some sharp objects, and then so these are the different types of the trauma that patients can have and come out.
Last case was an 18-year-old male, sir. It was in bakery where that sharp nail object was there.
Exactly. So that's
So
what.
what did you do with them?
Ma'am, all cases we did globe
Just
repair.
put the globe back
repair
and-
after tarsography was done. So all patients developed phthisis. After this 18-year-old, this child, because of this infection and continuous, we did inoculation for that young patient. Others all developed phthisis.
Okay.
Repositioned the globe
No,
and
there's
did
no other
tarsography.
option. Actually, ideally speaking, once the globe is luxated, enucleation is the procedure of choice. But in country like ours, probably I think so many other medical legal reasons. And just like that,
And
primary
also
repair
patient
nowadays everybody wants to pack it up and all. And by this off record, by putting the tarsography, I think we are hastening the thesis as well. So going the eyeball for the eyes is something like that. So too much of pressure. Anyway, thank you. Thank you very much. If there are no more participants, we come to the end of this session. I thank BOS for this opportunity. Thank you. I also thank my colleagues who have accompanied me and shared their experiences.
Thank you, sir. Thank you, ma'am. It's a nice experience for me. This is the first time where I came as a judge. It's a nice experience. Thanks for the BOS for giving me this wonderful opportunity. Thank you.
Thank you. Yeah, thank you.
Probably I have not accepted in the sense, please put me in some other session, I want to go for that session. Thank you. Thank you.